Welcome to Global Health Talks. It's kind of fun when you are able to chat with an eminently qualified doctor, but also somebody who's a friend, and that lends a little something to the conversationality of all of this. And I have such a splendid moment today. My guest and my chat is with Dr. Lynette Scherer. I will get out of the way. I will dispense with the qualifications of this young lady because we will then get into a little bit more interesting conversation. But Lynette is both, and this is kind of key to what we're going to talk about. She's not only a practicing trauma surgeon, she's also the CEO and I believe CMO as well of an organization. And this is kind of key to an overall topic discussion I hope we're going to have today about surgeons, the interesting subset or dilemma that they're facing in the OR. But in addition to that, the fact that many of them are in private practice and they're trying to somehow balance a lot of the rationale that they're getting in managing their own practices with going into the emergency room and being very, very frustrated with a lot of what's going on there. So just finishing up on the intro, Dr. Scherer got her MD at Tufts School of Medicine, did her general surgery and trauma critical care fellowship at University of California, Davis. She is board certified, American Board of Surgery. She's a fellow with the American College of Surgeons. Very importantly, she's an active member of the largest National Trauma Society, the American Association for the Surgery of Trauma. And it's only part of her mission, but she's committed to standardizing care for severely injured patients with the development of new modeling for how to service that need. Lynette, first, can we get a few definitions of terms? Because remember, in our audience are all sorts of folks who may not be as familiar with, for example, the term hospitalist. Can you tell us what a general hospitalist is?
Sure. So a hospitalist is typically an internal medicine trained physician who spends their professional career taking care of inpatients on the inside of a hospital. So they typically don't have outpatient elective practices, and they provide 24/7 care to patients who are inpatients.
And how would this contrast, and once again, it's time for another definition, how can we expand to a somewhat different category to define surgicalist, which I know is very, very close to you and to the work that SAMGI does?
Sure. So surgicalists are surgeons who are dedicated to the inpatient care of patients. And so a surgicalist would provide care to trauma patients or emergency general surgery patients and are dedicated to the inpatient care of these patients, as well as following them up in an outpatient clinic through their convalescence. So typically don't have elective practices, but are focused solely on the emergency practice, the emergency surgical practice.
For you, as someone who characteristically has had not only an elective practice, but you have a business background and you're such a multifaceted person, is there a conflict arising then under this titling of surgicalist? How is that affecting trauma surgeons?
Well, I think having a surgicalist model now really allows surgeons who are focused on and dedicated to trauma and emergency care to deliver care to these people as their professional practice. It allows us to separate the emergency from the elective service lines, which really leads to efficiencies in both. So a surgeon can be focused 100% on delivering emergency surgical care.
Now, you're a very, very skilled trauma surgeon. Why is earlier trauma and emergency surgery assessment becoming more important?
Well, we used to hear a lot about the golden hour. We haven't heard about that in a long time. And I think it's important to remind people that trauma is the leading cause of death in people under 40. It eclipses all other causes of death in that age group. And so when you think about it that way, getting the right care early, we know saves lives, and doing that regularly and consistently is the way to reduce death from the number one cause of death in that age group. And I will also say that even in the older age groups, trauma is a significant contributor to comorbidity. So really across the gamut, delivering early and good trauma care saves lives.
Well, you're not a complainer. You're someone who is, in addition to being a gifted trauma surgeon, you're also the CEO and CMO of Surgical Affiliates Management Group. I guess you better put the ink in there, because then that completes the acronym, or SAMGI. Am I pronouncing it right? SAMGI?
That is correct. We're SAMGI.
SAMGI. Okay. So now let's, can you tell me about value-based outcomes that allow you to offer a better model vis-a-vis SAMGI?
Sure. So one of the basic tenets of our practice is trying to standardize care. And that sounds easy when you say it, but it turns out it's hard to do because people are biologic systems. And so when you try to get everybody to do the same thing, the same time, and the same way, it can sometimes be difficult. But we're able to build teams of surgeons that use the best evidence and agree on how we're going to manage sometimes very complicated biological problems. And so when you do that, when you commit to a practice and get everybody on board, you reduce variations in care. And in our experience, that has led to many extraordinary outcomes. Obviously, the first is good quality patient care. We're very proud of that. But we also have been able to help hospitals have a reduced length of stay, which increases the number of patients the hospital can actually care for. So that's been important. We have reduced complication rates, reduced readmission rates, and have improved some of the financial performance of the hospital so they can actually pay for the services these patients require. And so by reducing variation in our practices, we can deliver all of those things. And I'll say also hard to measure, but equally important in my mind, is reducing physician burnout. It has really been topical lately, as we've seen. And this kind of model allows surgeons to come and take care of the patients they love taking care of. They're sick, they need intervention, they can do it. But it also affords them an opportunity to be away from the practice and know that their partners are going to care for their patients just the way they would.
Do you see clear international applications for what you're designing?
I do. I think that this model is applicable to any hospital that can perform basic surgical procedures. So if they are performing operations like removing the appendix or removing the gallbladder, this model is certainly applicable in those settings. When I came to SAMGI, we had 8 programs. We were focused primarily in California. We've now spread to almost 50 programs, and we are spread nationally, coast to coast and north to south throughout the country. So we've been successful in rural environments, suburban environments, big hospitals, small hospitals. The model's quite flexible and can be staffed to work for just about any circumstance. We're not international yet, But there's no reason to think that this model couldn't work in a hospital that has the most basic of surgical ability.
Well, I will tell you in the more affirmative sense, knowing both you, this wonderful team that you have, in particular, an old dear friend, your COO, Scott Flax. I believe he's COO, right?
He is.
Okay. Well, I think that you are internationally suited to push this forward, and certainly you would have our blessing along the way.
I mean, from a global perspective, really, you need a content expert, you need surgeons who want to do the work, and maybe some PAs or nurse practitioners to help. And then you have to simply decide what the best evidence is for providing care in that environment and get everybody to agree to do that. And then the key piece really is measuring the performance. So getting data back on the performance of the team and sharing that with the team, and then review, refine, and improve. That's a basic tenet of how we deliver this care. So it seems to me that any hospital that can perform those basic operations could institute a team like this.
You know, interestingly, Lynette, years ago, I think when you were just a little kid, no, I'm kidding. I actually spoke at Stanford University, and at issue at that time was part of my history that goes all the way back to the 70s when I paired up with then Surgeon General Thea Recoup. And an icon, absolutely, yes. With a funny tie. Yes. I got a call from him, and he asked me to come to Washington. And this was the impetus for me to get involved with medicine because I had been strictly consumer. He flew me out. I met at his home, and he said, "I want to tell you about something. It's called home health. And there's two reasons why it is starting to grow and thrive at 13% growth a year." And he said, there's two reasons for it. Number one, quality of life. And number two, reduced cost. And he explained a little bit about that. He used the example of titrating Uncle Ralph morphine. So would Uncle Ralph rather be in the acute setting or at home receiving the titration? And where would the insurance company like to have Uncle Ralph? Well, they sure don't want him in the acute setting. They would love to have him at home. Those drivers were what built home health, telemedicine, many, many other things. But at the time it was introduced, medical doctors gave it a lot of pushback. No, we don't want to endorse people being treated at home. Now, you're doing something that's very similar, and that's one of the reasons I appreciate it so much. You are looking at it's as much a business problem as anything, but given what we all know about medicine, for every dollar spent in medicine, 20% goes to actual treatment, and 80% is transactional, 80% is noise in the system. And the fact is many of the problems we have in medicine can be compressed down to where they offer, for example, the emergency room trauma patient better care, where they offer hospitals certainly a better bang for the buck, and where trauma surgeons and those aligned with trauma surgeons in the emergency room can just have a better theater of medicine in which to perform. I've asked the questions that I wanted to ask, but I don't want to turn you loose because there's a possibility I've missed something that's very important. And I want to give you just a few minutes to talk about anything that you feel I've missed, or anything that you feel is inert to this conversation?
Sure. Well, thank you for that. So you touched on a couple of things there that I just wanted to go back with. One is that something that ends up being a good idea in 20 years is often thought to be, just a bunk item when it first comes out. And I will share that my first publication on this type of practice was back in 1999. Presenting at a big national meeting, and I was essentially laughed off the stage, and then everybody told me this will never work. And I presented something pretty similar about 15 years later, and I was rushed on the stage because everybody wanted a job. So I think that for good ideas, you just need to stick with it long enough for everybody to catch up with you. In terms of the surgicalist model and what it really means for patients, hospitals, and physicians alike, I think without a doubt, this type of model brings the best surgeons to the forefront for patients when they need that care the most. So when you are shot or run over or hit by a train, you don't have the time to go Google who your surgeon's going to be. You are just at the whim of the hospital that you show up to. And it's important for me that at SAMGI, we deliver surgeons that you would choose to have if you had an opportunity. And I think that's great for patient care. For the hospitals, there is an ROI on this kind of a program because you cut that fat that you were talking about, that 80%, we cut that fat out of our models. And because of our ability to share resources across multiple sites, we can deliver these practices for very reasonable rates for the hospitals. And then for the surgeons, really being able to focus on this kind of care and simply being focused on being the surgeon and not having to worry about anything else in the practice is a real pleaser. So even though there's a surgeon shortage in this country, we still are able to attract the best and the brightest to this line of work.
Well, I have such great belief in you and what you're doing, and also coming from a different angle. I have those stories of people rushing the stage, furious in introducing the home health concept, no surgeon, no doctor wanted it. Okay. Then over the years, I got a call from McKesson HBOC saying, Michael, would you introduce our new e-pharma initiative? The e-pharma initiative was putting a computer next to the pharmacist, and now people could go up to a touch screen and get medical information. And when I introduced this in Las Vegas, they rushed the stage with me. What do you think? Who ever heard of such a ridiculous thing? We can't make the pharmacist in charge of this. Now, okay, like it or not, now I can walk into a pharmacy, to a Minute Clinic, display the proper symptoms to a registered nurse, get a script for Z-Pak, walk 10 feet, go get my Z-Pak, and go home. Nowhere along the way did I ever see a doctor. Okay. Then beyond that, the most recent one was a talk that I gave up north, where I'm trying to condition medical doctors to the emergence of telemedicine. Well, I got a lot of pushback on telemedicine too. All of these things have borne out to be enormously useful. And then boom, 2019 COVID hits. Now we have believers in a whole new general model. And I think what you're going to do for the surgicalist and that model is right at the very best moment in time, both domestically and internationally. We hope to speak with you again. I know that there will be successes, and please stay in touch with us and let us know how this bridge building is working out. We want to hear the continuum of this story, Lynette. Thanks for being our guest.
Oh, thank you very much, Mike. It's my pleasure.